Good evening to my Bethel friends and family. As you all know, the month of April is Minority Health Awareness Month. And with this month, we have two dynamic speakers, both medical doctors and Bethel members, who will be sharing with us from their perspective fields. On this evening, we have Dr. Mario Pyles. And to briefly share about Dr. Pyles, I saw he has some of this in his presentation, so I won't go into detail. He attended the University of Cincinnati Medical School as an internal medicine residency and cardiology fellowship. Excuse me, he did his cardiovascular fellowship at Indiana University, interventional cardiology fellowship at IU Med Center. He is board certified in cardiovascular disease, interventional cardiology, vascular medicine, and endovascular medicine. Hopefully, I got all of those right, Dr. Pyles. He is the medical director of cardiology and the vascular laboratory at Riverview Health. He is also a staff cardiologist at Ascension Medical Group, a fellow of American College of Cardiology, and a fellow of the Society for Cardiovascular Angiography and Interventions. So that is Dr. Mario Pyles. I am going to turn it over to him as he shares with us on this evening.
Well, welcome everyone. If I can see who's out there. Can everyone see the slides?
Yes, sir. I see the slides.
Yes.
Very good. This is just some of my credentials here, and we're going to be talking about hypertension, vascular disease. Hypertension is a disease of the blood vessels, and we're going to talk about also the cause and effects of this rampant disease process, which is very difficult to control, it seems to be. It's been around for a long time, and I'll show you how long it's been around here in a bit. So I have no disclosures. The objective of this lecture is to discuss the prevalence and incidence of hypertension in the United States. Also talk about the cause of hypertension and how we diagnose it. Some of the side effects of hypertension, what happens if we keep our blood pressure high, what happens to the body, what happens to our organs, and how do we manage hypertension in an effective way. And also, what are some barriers to treatment? Why aren't people getting their blood pressures down? What is the issue here? And overall, some conclusions. Well, the prevalence and incidence of hypertension, we know that about close to 1 million, maybe close to now 150 million people in adults in the United States, and over 1 billion people worldwide have hypertension. So this is very, very prevalent. 70% of the US adults over the age of 60 have hypertension, and the incidence will continue to increase because why? We're aging, we're getting older. 47% of the men have hypertension in the United States versus 43% of the women, but we know that women live a little bit longer, so they'll be catching up in their 70s and 80s, and they'll become more prevalent with hypertension than males. 41% of non-Hispanic, as African Americans, have hypertension compared to their counterparts, 28% of whites and Hispanics, and 25% of Asians. So it's disproportionately affecting African Americans in their communities. Hypertension is the leading cause of cardiovascular disease, killing over close to 400,000 Americans annually. That is significant. Close to 400,000. Clinical trials demonstrate that treatment of hypertension of goal leads to a 64% reduction in congestive heart failure. That is that your heart will survive if you get your blood pressure under control. Your heart will not get baggy and fill up with fluid so that all the blood and fluid gets into your lungs and makes you short of breath and causing more problems and even early death and maybe even heart attacks. A reduction of 40% reduction in stroke and a 25% reduction in heart attack. In the adult population, hypertension control is higher in Caucasians, 56%. So is there an equitable problem with that? Are the other Americans and across the world not getting treatment the way they should to get their blood pressure lower? Blacks 48% compared to their 56% counterpart, and Hispanics 47%, and Asians 43%. So it's therapy in the right direction of being equitable. Hypertension is controlled to less than 140/90 in less than 50% of the general population in the United States. Why is that? We have medicine to treat patients, people. Why is it still less than 50%? Why isn't it more? Progressive increase in cardiovascular disease may start to occur when your top blood pressure, called the systolic blood pressure, SBP, is over 115 millimeters of mercury. So we think that's a good blood pressure. We are told that's a good blood pressure, but when it starts creeping above that when you're young, get ready. You may have some problems when you hit your 30s and 40s, and when you're 40 and 50, when you're 60 or so, you're going to have some problems with cardiovascular disease. Cardiovascular mortality risk doubles with each blood pressure, the top blood pressure being 20 more than your baseline, and 10 milliliters of mercury more than your baseline for the diastolic. That is the bottom blood pressure increase. 2 millimeter drop in the mean office blood pressure. So when you go in and see your doctor and you just got 2 millimeter reduction, true 2 millimeter reduction in your office blood pressure, that's pretty good. It leads to about a 10% reduction in death and stroke, and 7% reduction in heart attack. That is significant. So what are some causes of hypertension? Well, these are the ones I want to talk about today. Disease process that affect the amount of blood flow and the resistance to blood flow in the body. So if you have blockages in the arteries, if you have very stiff arteries, you're not going to get the blood flow very well to the organ in which it needs to get to. And there are some inherent genetics that you can't do anything about, at least not now. We're working on that, gene therapy, to change genes out that lead to hypertension. That's coming down the pike. Lifestyle modification, diet, salt intake, certain drugs, illicit drugs, and things that you shouldn't be concerned with, physical activity, that is inactivity. This here, I'm not expecting anyone to remember this slide or go through this slide, but this here is to put a perspective on hypertension and how it affects all the organs in the body and all the arteries and veins. You get certain hormones that are produced by the liver, hormones that are produced by the lungs, that all in effect are inherently impressed by the kidney. So if you have a certain volume status, a lot of salt in your body, that's going to cause certain hormones to be released from the kidney and then convert all these different hormones and proteins to certain proteins here, or hormones that cause the blood pressure to elevate. And these hormones here can affect all of the arteries and veins in the body and cause the arteries and veins to work against you. Now, sometimes we need our blood pressure to go up if our blood pressure gets too low when we're dehydrated. So we want to have our blood pressure to go up, because if it's too low, we pass out. So we don't want that to happen. So, but for the most part, this renin-angiotensin system works correctly, provided that we eat and drink the right things appropriately. So I just wanted to show you this very complex slide. And this is not the appropriate things to eat. If you're going to eat these, you better be working out really, really quick and get the salt out of your body. But sloth, watching too much TV. Now we're seeing young kids that are 10 and 12 years old having diabetes, having hypertension. We're doing a lot of video watching, a lot of TV watching on a computer, not getting out and having fun and running around like I used to do when I was 11 and 12 years old. I think I probably watched maybe 2 hours of TV on the weekend. We were out playing, cutting the yard. So these things here, not very, very good for you. They just build up fat and clot and plaque in the arteries and making things a problem. Remember what I said, that hypertension was around for a long time? Yes, the black Egyptian princess died about 550 BC at the age of 40. And this is the CAT scan of her mummy. This is Princess Amos Ameret Aman, the daughter of the last pharaoh of the 17th dynasty, Tao II. Let me take you through this mummy here. Here's the head, as we all can see. And then this is the CAT scan. These are the lungs. This is the vertebral column. And then what runs just above the vertebral column is the aorta. And what is this white stuff here? That's calcium. So why would a 40-year-old have calcium in her leg, have calcium in her right heart artery, and her artery on the back called the circumflex at 40 years old? Most likely she died of a significant heart attack. But why at 40 years old? Well, they're carried around in reverence. They didn't walk very much. They didn't have refrigerators. So they had to salt all their meat to preserve it. And all that did was make the body hypertensive and the vascular system just become engulfed with plaque. And this mummy shows that hypertension has been around for a very, very long time. Very long time. And we can do something about that. And we see here when you get your heart scan, we call it a coronary calcium score. We're just looking for spickles of calcium in the arteries, in the heart arteries. And it has some prediction of your cardiovascular risk and outcomes. You can see here, this is the proportion survival, and this is the years out, 4 years. So if your calcium score is from 0 to 100, you got a pretty good, over 99% chance of surviving without a heart attack up to 4 years. But as your calcium score continues to go up, your survival goes down. So we got to watch out. That's a great screening process just to get a heart scan, a $49 heart scan. You can tell where your numbers are and what you need to do to correct that problem so you don't get hypertension, heart disease, a stroke, etc. over time. So again, calcium is the bad thing in your arteries. So how do we make the diagnosis? Well, here we go. You go to your doctor's office for one thing. You got to see your doctor at least once a year so that they can do an appropriate history on you, check to see if you have hypertension, what's your cholesterol, you have sugar problems like diabetes, do you smoke, you have a poor diet, they can go over the diet with you. How's your activity? Are you getting about 150 minutes a week that you should get, which is appropriate, which is now recommended? Do you have a family history of hypertension? Or do you have sleep apnea? Okay, are you waking up at night, short of breath, stop breathing, those sorts of things, which maybe you may not know, but somebody may know that you're doing that. And that is a risk for high blood pressure. That's also a risk for sudden death in your sleep. It's sleep apnea, obesity. Those are the things that your doctors can talk to you about. And they'll do a workup, they'll do a physical exam, they'll listen to your arteries in your neck, they'll listen to your heart, they'll listen to your abdomen to make sure you don't have an aneurysm growing. Because one of the horrific problems and side effects of hypertension is developing an aneurysm in your abdomen, an aortic aneurysm. They may draw some blood, looking at your sugar, looking at your kidney function, to make sure your kidneys are functioning appropriately and filtering all the bad things out of your blood, making sure your thyroid is fine. Because we know that high thyroid levels, called hyperthyroidism, can lead to significant hypertension and fast heart rate. They can look at your blood count and make sure you're not anemic. Your hemoglobin is not too high or too low, mainly too low, because that could be catastrophic. And they may do a dipstick urinalysis to take a look and see how much protein's in your urine. If there's protein in your urine, it is abnormal. You should not have protein in your urine. When you see protein in your urine, that means that your kidney is not functioning right. The basement membrane of the filtering process has been broken down or is breaking down, and it can lead to some significant problems. This here is called a metanephrine. This here can determine whether you have a tumor that is growing in your abdomen called a pheochromocytoma. That itself can lead to a high blood pressure situation and something that can be very wrongful with you. The aldosterone renin system, that complex diagram that that regulates what the key puts out in response to volume status and salt. Is it too high? Or do you have a tumor that's producing that? Those are sorts of things that they can look at. An EKG to see if your heart's involved from hypertension, a chest X-ray to see if you're retaining fluid in your lungs, and an echocardiogram. That is an ultrasound of the heart. We can tell what your heart function looks like, what your status of the thickness of your heart. If your heart is too thick, then it's probably pumping against a lot of blood pressure to get out into the aorta to fill the rest of your body with good, nutritious blood. So echocardiograms are helpful. Maybe an ultrasound of your kidneys, looking at the kidney arteries to see if there's a blockage. If there's a blockage in your kidney, the kidney is going to scream for higher blood pressure so that it can get perfused. If you have a significant blockage in that kidney, you need higher blood pressure to push that blood to the kidney so the kidney can get satisfied with nutrients. What about a carotid artery here? Carotid artery ultrasound, where they're looking at your arteries in your neck, called the carotid arteries, to see if there's blockages. If there are, high blood pressure can start flicking things off to your head and causing you a stroke. And we already talked about the Cornish score. The ACC/AHA guidelines for hypertension changed in 2017 and is yet to change back to any for the past. So this is basically what they're saying, that a normal blood pressure, systolic blood, that's the top blood pressure, that's what the heart looks at when it's pumping, is the systolic blood pressure, should be less than 120. The diastolic blood pressure should be less than 80. That's the blood pressure on the bottom. That's the blood pressure that the heart looks at when it's trying to fill blood into the heart arteries so that the heart gets nutrients. If that's too high, that's going to be a lot of blood pressure that the heart has to press up against in order to get good nutrients to itself. You don't want to starve the heart. That's not a good idea. And if elevated blood pressure starts at 120 over 129, this is early hypertension. So we need to watch people who get into this range, because it could it could warp into something like stage 1 and stage 2 hypertension, which is 130 to 139, and then stage 2 is greater than 140 millimeters of mercury. The diastolics here are also elevated. So this is what we're actually looking at. These are numbers that you need to know. So always know your number. What is your blood pressure? Because you don't want to end up with any bad side effects from hypertension. Well, what are the side effects of hypertension? Well, let's look at the brain. Well, you can get a stroke from decreased blood supply to the brain. You can bleed into your spinal cord because there's too much pressure in your brain, and that can cause little capillaries to break and you start bleeding into your spinal cord and have a spinal cord stroke. That's not good either, because that will definitely lead to paralysis. You can decrease your brain volume. This is how we talk about when people have had blood pressure elevation their whole life, they get dementia. They get a vascular dementia. Their brain starts to shrink because it never really got good blood flow to it over several years. This is not anything that happens acutely. This is something that happens over a long period of time. Then you can get heart failure. Your heart gets baggy. First, it gets very, very thick, and then over time, it just says, I can't do this work anymore. So it starts to get baggy, and you get heart failure. You get an irregular heartbeat called atrial fibrillation or atrial flutter. That can lead to a horrible clot, a significant clot that can go to your head and cause a stroke, can go anywhere else into your body and organs and cause organ problems. Or kidney effects. Kidney failure may require dialysis, and you don't want to be on dialysis. So you want to prevent that. That's something that occurs over time to get on dialysis. So if you keep your blood pressure under control, most likely you will not have to deal with a dialysis. Side effects in the eyes. So you have all these small capillaries in the eye that, if it's affected by the blood pressure being too high, it can start rupturing. and then you can start bleeding into your eyes and have eye problems. So that's not good. Well, let's look at some of the brain effects, which is stroke. And here's some of the symptoms that may be abrupt or gradual onset. Slurred speech, we all know about that. Facial droop, some confusion, you just can't remember anything acutely. Vision problems, double vision, loss of balance, falling over, severe headache, the worst headache in my life. If anyone says that, you better get them to the hospital, call 911 because they could have a cerebral aneurysm. And you don't want to miss that. Unable to move extremities or numbness or dizziness or just some memory loss. Well, I have memory loss sometimes too. So, but I mean, I don't think I'm having a stroke, but basically something that occurs acutely where you just can't remember anything right off the bat. And that could be a problem if you never had that problem in the past. So this here represents the normal CAT scan of the brain. Here's the gray matter here. You see these nice ventricle windows, these windows here where all the spinal fluid drains into. It looks pretty symmetrical. All this looks pretty symmetrical. The skull looks pretty symmetrical. There's no fractures. This here represents what the artery is fed by, what the brain is fed by. It's called a carotid artery. It separates into an artery that goes up into the head, into the brain, called the internal carotid artery, and it separates also into an external carotid artery that feeds all the face. So sometimes people have facial numbness, facial problems. They could have had a clot or something flick up into the area here and cause some type of reduction in blood flow to the face. Or they could have a clot to go up here into the brain and cause an acute neurological event, which will have to be dealt with very, very quickly. And this is what happens if you wait too long. Okay, this is hemorrhagic, means bleed. So this black part here represents the initial stroke, and then they just bled into this area. Okay, and what happens? You get a shift of mass effect on these ventricles. So the cerebral spinal fluid can't drain, and then this brain continues to swell, and then it drops down into the base of the skull, and that's called a herniation. And that's it. You go home to the Lord with that. So you definitely don't want to have to bleed. This is how it looks like early. So it starts to bleed, and then you end up with this. This is a right stroke here. You can see here it's looking very, very, very early. You still got your ventricles open. You're still somewhat symmetrical, but it's starting to what we call E-face, where this here mass is affecting this ventricle of the brain, and you can't drain the spinal fluid. So let's look at some symptoms of heart attack. This is the other effect of of the of hypertension. Well, the background, I'm just going to go through this fairly quickly. About 92% of recognize chest pain. Okay, approximately 92% recognize chest pain as a symptom of heart attack, but only 27 were aware of all major symptoms and knew to call 911. So if you're having a problem, please don't drive. The chances of you having a significant event and taking someone else with you when you hit them with your car is catastrophic. Call 911 if you're having symptoms. Don't try to drive yourself to the emergency room. Approximately 47% of sudden cardiac death occurs outside of the hospital. So if you think you can make it, well, that's not a very good chance at going to Vegas for 47%. Some people may bet on it, but I wouldn't bet your life on 47%. So call 911. Symptoms of heart attack, we know that: chest pain, upper body discomfort, arms, back, neck, jaw, upper stomach, shortened to breath, nausea, lightheadedness. Women really don't have the types of symptoms that men do. They usually have kind of like a sharp pain, dull, burning trigger. Emotional distress is triggered by it. Approximately 10% of the women have no symptoms and just suddenly drop, or they just feel breathless walking up the steps. So any of those things that would occur with activity, the clock is ticking. You know, time is muscle is time, time is muscle. By the time you hit about 4 hours, 5 hours, 6 hours, up to 24 hours, you've already had your scar, already had heart damage, and you can't rebuild heart. Once the muscle's gone, it's gone. This is here when you have a heart attack, that blood flow to that area of the heart, that heart dies. So as soon as you have the symptoms, we need to get you to the nearest hospital that can perform angioplasty. That is balloon angioplasty, where we open the vessel that is going directly to the heart. This is what the lab looks like. You have this kind of octopus looking gadget here called the catheterization laboratory. You lay on here, and then we're getting into your artery very, very quickly. Sometimes our door to balloon time and open up this vessel is can be 14 to 15 minutes, and we stop the heart attack. So it's best that you get to the hospital as soon as possible, because here is the right heart artery here in red, and there's a blockage there. We can go in here with the catheter. We go through your groin or through your wrist and get the catheter, which is about 1.5 millimeters, into the correct artery where you're having a heart attack. And we inject a little bit of contrast or dye and find out where the blockage is. And then through this little catheter here, we wire and get across that blockage, put the wire through there. Then we put a balloon in here and inflate that artery so it gets big enough so we can put a stent in. And then we're done. Very quick. And this is what the artery looks like. It looks almost brand new in that area. So we could do that for you. Interventional cardiologists can do that. Now, if you come in when you have severe shock and you're needing to be on a balloon, and you're a balloon pump, and you need to have an intubation where they putting you on a breathing machine. This person came in, just waited too long. This artery here was totally blocked off, had a widowmaker, and we didn't have time to ship that person for surgery. So we went ahead and did surgery for him with stents. We opened up this artery here called the left anterior descending artery. We also fixed that, what we call the widowmaker, the left main, put a stent in there, put a stent in there. So 3 stents. And this is what he looked like afterwards. He did very, very well. So in an emergency, we can fix arteries and make them better for you. But still, if you have a blockage like this, surgery is indicated. But we can help you out during the interim of your heart attack so that you can survive. So management, we'll go over this pretty quickly. We know that weight loss can lead to about 5 millimeters of mercury, reduction in blood pressure. So we know that 2 millimeters, remember, just in the office, can get you some significant reduction in your morbidity and mortality. Healthy diet, the DASH diet, rich in fruits and vegetables, can reduce your blood pressure by 11 millimeters of mercury. Reduce in dietary salt, 5 to 6. Enhancement of your potassium. Physical activity is a big one. Remember, I was telling you that we need to have 150 minutes a week. And I don't really talk about people drinking alcohol, but if you have some wine, I'm saying maybe 3 or 4 ounces with your meal can reduce your blood pressure. We're talking about red wine, okay? But I'm not telling you to do any type of drinking. I'm not telling you to start. So dynamic resistance, isometrics. If you can't get up and walk, just get some balls and just do these isometrics to increase your heart rate and blood pressure while you're sitting. That can be also helpful. And you can see it can reduce your blood pressure. But here you go. Protein is good. Carb, these good carbs, they're good. Fats are good here. Fish, all the nuts. Those are the good fats. What happened here? There we go. Okay. Now, how do we manage blood pressure? Well, your doctors may put you on these types of blood pressure medications. Sometimes they'll try, if the blood pressure is not too high, sometimes they'll just try diet and exercise and lifestyle modification. But these are the types of medications that you may be put on. I'm not going to go over all these. I just wanted to touch upon these. This one here can cause a lot of dry mouth. I get a lot of complaints when patients are put on this medicine called clonidine. It works in the brain. So it's a central acting agent that reduces the blood pressure and also may reduce the heart rate at the same time. So this here is usually given as an as needed basis if your blood pressure is too high, intermittently. So, and it can cause a really dry mouth. So if you're on that, that's probably the reason why you're getting a dry mouth. Devices like stents to put in the arteries, in your kidney arteries, can be helpful if you have severe blockages in the kidney arteries. Remember, the kidney needs to have blood flow too. And if it doesn't, it will scream and start producing this hormone I showed you on this schematic, this diagram that we talked about previously called renin. And that will cause you to have a lot of blood pressure elevation because it actually starts this cascade of hormone production to cause your arteries to narrow down and blood pressure goes up, and so but more blood can be pushed through the kidney arteries. And there are also some ablative techniques that we won't go over now, but that are in the making, where we do an ablation of the nerves. That is, we put a little catheter in the artery, and then it emits certain high frequencies that destroy some of the nerves around the arteries, and that can lead to a lower blood pressure. So we're still doing studies on that. This here, I'd just like to show you, this is the kidney artery, and this is not a normal kidney artery. This is an artery that has a lot of these different curlicues in here. We call it fibromuscular dysplasia. This person is born with fibromuscular dysplasia, where they started having high blood pressure and they're 15, 16 years old, but they didn't get this diagnosis until they're 40, 50, 60 years old. And by that time, they've already had kidney damage. You can see here the kidney is shrunk, and these arteries out here should go way out here to the end of the kidney, and they're not, because this kidney was screaming for years with decreased blood, with a need for blood pressure. So we cure that by putting a little balloon in here, but not a stent. And we can balloon that area open and make it much better flow. And you can see how much better now the arteries are filling the kidney. Not the best, but if it were caught when the patient was 20 or 25 years old, this wouldn't have been an issue. So hypertension is very, very important to treat. What are some of the barriers? Access to healthcare, equitability, low socioeconomic status. Are they getting to the doctor when they should? Unsafe neighborhoods prevent people from getting out to going to the doctor, or having clinics in those neighborhoods. Those are the things we need to talk about. Minimal access to fresh, healthy foods in their neighborhood. Are they going down the street and getting bananas that are already relatively brown and not and lost all their nourishment? The apples and other fruits that can be a problem. Do they have healthy food in their neighborhoods so they can get those healthy foods and they can eat healthy at a reasonable price? Healthy food is starting to become very, very expensive. Minimal doctor-patient interaction, that can be a problem. People not going to see their doctor, and non-adherence to treatment goal. So when you see your doctor, the doctor wants to put you on a medication, and you say, well, I'm not going to do that. I'm going to try some herbal medications and do it myself. Please listen to your doctor. Your doctor has gone to school long enough to know the side effects of hypertension. So here is an interesting one. It's the primary endpoint of the reduction in black barbershops in non-Hispanic black men aged 35 to 79 with blood pressures greater than 140. So what they did was that they did a study. So you went to the barber, and they had a pharmacologist there, and the barber talked to you about your blood pressure and the need to go see your doctor. And that was the interventional group. In the control group, that didn't happen. So just your barber talking to you about your blood pressure actually caused a reduction in that blood pressure over time, because it caused you to be compliant. And there was a pharmacist there at the barbershop actually making recommendations and informing that person's doctor what the blood pressure was outside the office. And they were put on these drugs here and optimized over time. And you can see that there was a significant difference between the interventional group and the control group. So these are some of the things that we're thinking about doing, and some of the things that we've shown to be helpful. So in conclusion, hypertension is a complex vascular, okay? It's an artery problem. It's a disease of the artery and difficult to manage, because you got to do a lot of things to make sure that you're following your doctor's recommendation. It's hard to get out and work out 150 minutes a week. It's hard to take those medicines every day. It's very difficult to eat in a nourishing fashion every day, and to go to the store and get fresh fruits and vegetables. That's very difficult, and you may not have access to that. So these are the things we need to think about when we're talking about treatment of hypertension. Hypertension is a major risk factor for cardiovascular disease and stroke, which leads to increased morbidity and mortality. We know that by having a stroke, having end-stage kidney disease. You're not going to live very long if your kidneys don't work. Having a heart attack and congestive heart failure. It is important to understand the cause of hypertension in order to provide good care and compliance. I mean, you have to know yourself what the causes and the effects of hypertension are on your body. Because if the patient, which would be you yourself, if you have high blood pressure, if you're not compliant, then nothing that the coach, who's the doctor, can do. The doctor's the coach. He's telling you, or she's telling you what to do to help you out. Got to be compliant. In the 2017 recommendation, those are tough blood pressures to achieve, but they're achievable over time. It's not going to happen overnight. Treating patients to target blood pressure goals may reduce the incidence of cardiovascular, untoward, or side effects. And we know that. Get the blood pressure down, things improve. Dissolving the barriers is the most important thing. Those people who cannot get access and equitable care to treating their hypertension, they just have heart attacks and strokes, and actually have more problems trying to get that critical disease treated. So we need to help. We need to find some way of doing that. And mommy, what should we eat for lunch? You know, the kids are looking up to us. They're looking up to us for good eating habits. How we start off. We don't start off with hamburgers, French fries, and Coke. You know, how we start off our morning. The kids are always looking towards us for example. Okay? It does it in the wild, and we're no different. Kids always look up to us. And to get your blood pressure to goal and drop it into the hole. I thought I'd share this with you guys because I think my blood pressure that day was actually getting up. I was being videoed, and I had to slam that thing. I thought that was cute. So yeah, give yourself a high five. Get into the rhythm of getting your blood pressure under control, so you can have a good smile and be happy, so you can have a long life to be with your children and your grandchildren. Thank you for your attention.
Dr. Pyles, thank you for that information. Are there any questions for Dr. Pyles? You can unmute and there's one in the chat box. I was gonna ask the $49 scan because I've heard about the $49 scan before. Is there an age that you suggest people start those? I've never had one, but I will get one if it's probably time.
I'm trying to start my video here. I gotta stop sharing here. Here we go.
You got it. I might can make it. Okay.
Okay, there we go.
And feel free to turn your cameras on. We want to see you guys.
I want to see everybody.
The question. So I was just wondering, when do you start getting that $49 scan? And then Lavella asks, at what point in time would a workup for echocardiogram or kidney artery ultrasound be recommended? And why do heart attack symptoms differ between men and women?
Okay, well, let's take your first one about the coronary calcium score, the heart scan. I usually wait to around 50 years old.
Oh, I got time. Good. Okay.
To get those. Or if you've had some type of event that was other than cardiovascular and your doctor's worried about that and they want to really treat your cholesterol to goal and you're kind of not wanting to take any medications, then a coronary calcium score could be very helpful, because if the calcium score is 0 at this build up after the age of 50. So if you had a 0 calcium score, you may have a pretty good feel about yourself and say, well, nothing wrong with me. But you have to understand that heart attacks occur mainly with a fluffy fat plaque that can rupture. Calcium is really a stable condition for stable plaque. So even though you have a zero coronary calcium score, if you have high risk factors, you can still be at risk for having a heart attack. And what was the other? Who had another question?
Lavella asked,
Yeah,
at what point in time
renal.
would a workup for echocardiogram or kidney artery ultrasound be recommended? And then why do the heart attack symptoms differ between men and women?
Okay, yeah, for the echocardiogram, that really depends on your symptoms. If you're having shortness of breath, if you're having swelling in your legs, I think an echocardiogram can be very helpful because what it can do is look at your heart function on both sides, your left and your right side of your heart, and also determine what your lung pressures are as well. So it can pick up what we call pulmonary hypertension, which is hypertension in the lungs. So if you start to have these symptoms, you can go ahead and ask your doctor maybe to consider that. But we just don't screen everyone with an echocardiogram unless it's indicated. If you have a family history of a thick heart called hypertrophic cardiomyopathy, where the heart is very, very thick, we call the Hank Gathers, the young basketball player that died on the court. Those are the reasons why we would do a screening echo, and I think your insurance will pay for that. But just to have an echocardiogram, you can have it if you want to pay for it, but I doubt your insurance will pay for that. The same thing as renal ultrasound. If you don't have hypertension or you don't have protein in your urine, again, you can pay for any test you want, but for your insurance to pay for that, it's probably not going to be done. So you have to have some symptoms or some abnormal baseline lab test. And why are women symptoms different than men? No one really knows, uh, but it could be social type of things that what I've heard from the patients who tell me, said, well, doc, I don't have time to be worrying about that. I got a lot of stuff to do at home, and sometimes I feel short of breath, but I just don't know. I just think I'm just not active enough. Those are the sorts of things that my patients tell me. But why are they different? We don't really know why women have different symptoms, because some women have the same symptoms as men. So, but on the most part, they have breathlessness and just fatigue. But they may be having chest pain and just not telling us all the time. But there's no physiological reason why men are different than the women as far as ascertaining symptoms.
And we have two more questions in the chat box. Somebody asked about shingles and pneumonia vaccines, at what age you should start getting those. And then Reverend Marla had a heart scan about 8 years ago. Is that something she should ask them to do again?
As far as the shingle, I'm not a pediatrician or a family doctor, so I don't really know those age. But those who've had shingles before, and they've been bad shingles, you could probably get those definitely over the age of 50 to get a shingles vaccination. But those would probably be better to be answered by your family doctor. I don't want to give you out wrong information, because I always have to ask my referring doctors when to give these vaccines. And what was another question?
Reverend Marla says she had a heart scan about 8 years ago. Is it something that she should have them do again?
Yeah, we always tell people, if you've had underlying coronary disease, if you've had a heart attack, or you've had an event, there's really no reason to get a coronary calcium score, because we've already made the diagnosis. Now, those who don't have any symptoms at all and have had a baseline coronary calcium score, we say every 5 years it's helpful to make that determination. Because one, you don't want to see it progressing very fast. And there's some things we can do: high intensity statin use, Lipitor, Pravachol, those sorts of things, Crestor, to reduce that calcium buildup in the plaque too quickly. So again, every 5 years, if you're going to do that, it's appropriate.
Okay, the heart scan that I received, Dr. Pyles, was normal. Everything looked good.
Mm-hmm.
And I don't have a history of any heart issues or problems. at least not that we know of. So you're saying even though I had it 8 years ago, I should get it like every 5 years? Is that what you're saying?
Yeah, if you're concerned about buildup of calcium, because as you get older, you're going to have calcium anyway. So you remember that slide I told you about that 0 to 100? I still think within that range, and as you get older, it's probably okay. But any calcium at all means that you probably need to start a medicine called statin, like the Pravachol, the Crestor, the Lipitor, those sorts of things. But if you've already had a 0 calcium score and you have no risk factors, I mean less than 2 risk factors, probably not worth getting the radiation stored in your body by doing all the testing.
Dr. Pyles,
Yes.
Jerry Green,
Hey, Jerry.
excellent presentation. If you have a little fluid around your ankles and your feet of a morning, could that be what? Could that be more blood pressure? Or what could be some of the symptoms of that? I mean, what could be the cause of that?
Yeah, that's very, very important to note it, that you said in the morning.
Yes.
Yeah, usually some people may have the swelling towards the end of the day, and that's because their veins aren't strong enough to contract against the gravitational force of the earth. So blood starts to pool in their veins. And that's called, we call venous insufficiency. And that swelling usually gets better in the morning. But swelling in the morning can suggest that you're retaining too much fluid, and that you may have some issues with the heart and the kidney. So that's something that you should be, thinking about and talking to your doctor about, because you really shouldn't have fluid in the morning around your ankles. Now, it's also too that if it's just a little bit of fluid there and it's not pitting, if you can't press on it and cause it to pit, then it's probably something to do with salt retention.
Okay.
You may just need to reduce salt in your diet. But I would talk to your doctor about that, because that's key. When you say swelling in the morning, that's key, that we should, as to be an antenna. Ooh, well, what else is going on here? What else should we be looking at?
All right, thanks.
Teresa also had a question in the chat box. She wanted to know, can hypertension be reversed with or without medication?
Oh yeah. We and depend on how high it is though. Essential hypertension in the 140s to 150 range. I usually don't start any medication. By the time they see me, they're probably already on 3 or 4 medications. Their doctors have already started that. So we do lifestyle modification. We look at the types of diet, the DASH diet, fruits and vegetables, good carbs with the nuts and fish with not a lot of oil cooked in it, be baked meats, lean things of that sort, decrease in your salt. Those are the things, as well as exercise, that 150 minutes a week. You guys remember that? 150 minutes a week.
Thank you.
It's hard to get that, because I'm having a harder time now as I'm getting on to get that 150 minutes a week. But yes, you can do lifestyle modification and diet and see how you do over 3 months, and follow that up with your doc. It's also good to take your blood pressure at home, get a blood pressure monitor to do that. And when you take your blood pressure at home, you got to be in an area where it's quiet. You got to be sitting in a chair, sitting up. Okay, you want to be erect, and you want to just relax and wait about 10 minutes, then take your blood pressure.
Okay.
So you got to be erect and sitting in a quiet area. Okay.
And take 10 minutes.
Take about 10 minutes just to relax, and then take your blood pressure.
I've been doing that.
Yeah, go ahead.
I'm Teresa again. Is there really such a thing as white coat syndrome?
Yeah, there is such a thing as white coat syndrome. There's some, and I've had several patients say, "Well, doc, why you keep raising my blood pressure?" Because, every time I come to the office, my blood pressure's high. I said, "Well, I know that, but it's still a risk. People think that white coat hypertension is not a risk. It's still an inherent risk because it's an emotional subconscious surge of certain hormones that cause your blood pressure to go up that you're not even aware of. So blood pressure doesn't go up for nothing. So there's hormones that are being secreted to cause your blood pressure to go up. So some emotional state can do that. So anxiety can cause your blood pressure. So we usually don't check our blood pressure when we are very anxious. We don't go, hey, I'm going to go home, check my blood pressure, I'm anxious. We don't do that. So I think the office blood pressure is a very good indication of what you do when you're stressed. And so if you're 200, top number when you're coming in to see me, yeah, I'm going to start you on something. Because when you relax, you're probably about 150. And that's too high. So, but you're right, there is something called white coat hypertension, office hypertension, but it basically is a risk factor. It should be taken seriously. So we ask people to do ambulatory blood pressure readings at home in a quiet situation. Do it in the morning, do it before you go to bed, and take a log of it and bring that back to your doctor in about 2 weeks or something.
Okay, thank you.
Which, as Dr. Pyles talks about physical activity, I have challenged the members to get moving. Let's see, we have 9 days left in this month. When I first sent it out, it was 15 days. And so I encouraged everybody to get moving for 30 minutes a day or at least a mile. And I want to shout out Randy and Ivy. They did 5 miles. Was that Sunday? I posted their picture. Shayna rode her bike, and then Dr. Brandy sent me her picture after she rode her bike. So I just want you to get moving. I don't care how you move. If you want to dance, if you want to walk, if you want to lift some weights, if you want to run, for a couple reasons. One is Minority Health Awareness Month, and we know that African Americans are not getting enough physical activity. So I want to highlight our members moving. As a matter of fact, I have been convicted after this lecture, so the sun is still out. I think I am going to try to get moving before this day is over. So everybody get moving. I don't see any other questions in the chat. If there are any other questions, please.
I have one, Reverend Mindy, for Dr. Pyles, if you don't mind. Okay. Dr. Pyles, I had a heart scan. It's been 5 years ago now, and my calcium level or whatever was at 60%, which they said wasn't bad. So should I have another one now?
Well, was it 5 years ago?
Yeah, 5 years ago. But and also with that, that's when I found out that I had cancer. They said the calcium was at 60%, which I thought was bad, but they said that was good because you go up to 600. But then I was diagnosed with that cancer by having that heart scan.
Oh, okay. Yeah. So if it's been over 5 years and you haven't been diagnosed with any heart issues, then I think it'd be worthwhile getting another score to see if it's gone up.
Okay. I get the CAT scans all the time. Actually, I talked to my lung doctor today, so I get the CAT scans all the time, but I haven't had that heart scan. And for me, I don't know, it just seemed like that $49 heart scan was better than a CAT scan because they picked up the cancer with the $49 thing. I said, that's the best $49 I spent.
Yeah. No. I mean, because when they're doing the heart scan, it's actually a CT scan of the chest, but mainly focusing on the heart artery. But as an aside, they can't ignore any abnormalities that are seen doing that during that test. So they have to report everything. So if you have an aneurysm in your aorta, they're going to report that. If you have something in your lungs, they're going to report that. So, but it's not the same as a CAT scan of the chest. I mean, they get really detailed in the CAT scan of the chest because they're looking for certain things in the chest, and they may also pick up some calcium in the heart arteries, but it's not a calcium score.
Okay.
So those are two different techniques, but happen to overlap as a reason why they were able to procure that diagnosis for you. So that-
Okay. Okay, makes sense.
Mhm. I just want everyone to remember what that brain looked like when it was bleeding. Yeah. You do not want that to happen. And it's all preventable. But you can't bring brain tissue back either. Time is brain, time is heart muscle. So if you have any of those symptoms, you got to see someone very quickly. Go to the emergency room, call 911. I always call 911. Don't drive yourself. It's very dangerous. Okay.
Well, thank you again, Dr. Pyles.
Good.
Wonderful, wonderful presentation. I also should have shouted out Brother Jerry. He came to the church the other day, and while we were waiting for somebody to come fix something, he got his physical activity by walking through the open area. So we'll take that too, Brother Jerry. Thank you for getting moving.
Also play golf.
Oh, and he played golf, yes. So yep, everybody, please, please, please get moving. And not just in this month, but every month. Thank you again, Dr. Pyles. Next Wednesday, 6:30, same link. We will have Dr. Janet Bennett, and she will share with us about mental health from an African American perspective. So I'm just excited because we got church members who can share about this stuff. I know sometimes we're a little more hesitant if we don't know them, but we know Dr. Pyles and he answers our questions. So we should really listen to what he shared with us on tonight.
Man.
Amen. Thank you so much.
Hey,
Yeah.
thank you.
Have a wonderful.
Excellent.
Thank you.
Thank you.
And if there are no more questions, I'm going to go ahead and end the meeting, but y'all know I like to warn because I feel like it hangs up on people.
You like to push that leave button.
You have to hang up on us.
I just feel like it's so rude because it's just like meeting ended. There is no warning. So I do like to give people a warning sign before I hit the meeting end button. But everybody have a good evening.
Okay.
Bye-bye.
Good night. Bye-bye.
Bye.
Bye-bye.
Bye.
5, 4, 3, 2, 1.